Hello, everyone. Hi. Welcome to our Doctor's Lounge. And today we just have a special show for you. And we're so proud that we have Dr. Karma Warren to come on. And we're going to be talking about varicosities and venous problems of the lower extremities. But be first, let me do my Doctor's Lounge introduction here. We're a group of Black physicians that are here for two basic reasons. Number one is to make sure that people of African descent get a chance to improve their health. Number two, to encourage young Black males to go into medicine because it's a big problem. It's a big problem because our young men are not. They're being snatched into other areas of specialty. So we want to encourage those young guys that are interested in science to come on and think about medicine and as a possibility of something that you may want to do for the rest of your life. Our webinar is every second Saturday. And please let everyone know it takes a village. All they have to do is come in, as you know, to OBHealthy and click that doctor's tab and join. And because we're here, truly here to answer your medical questions. If you want to see our past webinars, all you have to do is go to the website OBHealthy and click on our YouTube sign. And all of our past webinars are available there. It's very easy to get. Remember to subscribe to YouTube so that we can continue to bring it to you that way. Righty? I want to say, don't be afraid to type in your medical question. A lot of times, somebody may say, well, my typing's not that good. It doesn't matter. It doesn't matter. The question can be as small as you can make it or as large as you want to make it. We will try to answer your medical question today. All righty. The most important thing I can say. Routine already in the old. And he closes it out. All righty, we have Dr. Court. Can you put yourself on mute? I thought it was Dr. Court. We have a voice coming through. The most important thing I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, truly, only your doctor can best take care of you from a medical perspective. I think I've covered everything. And what I would like is we have a nice group of physicians here today. We're going to get everybody introduced. And Dr. Duncan, can you start us off, please?
Sure. So good afternoon. Matt Duncan. I'm currently a fourth year psychiatry resident at Ocean University Medical Center, finishing up residency and starting an addiction psychiatry residency at University of Pennsylvania in July. So happy to be here again for this month.
All right, thank you. Dr. Court, please. Dr. Court, you're on mute.
It's okay now.
Yep, we hear you.
Dr. James Court, internal medicine. My office is in East Orange, New Jersey.
That's all you're going to give us today?
Yes, tonight. I'll save it for later.
Save it for later. All right, he's modest. Dr. Ali from California.
Hi, my name is Mazhar Ali. I'm a gastroenterologist with Scripps Clinic in San Diego, California.
Excellent. And we appreciate you taking the time. I know the time difference from here to there is straining sometime, but you do it, brother. You do it. And
I'm happy to be here.
All right. Dr. Sprott, please.
Yeah, Kendall Sprott, retired pediatrician. I did pediatric critical care and general pediatrics.
Excellent, excellent. And I'm Dr. Omar Bey, retired pulmonary critical care physician. Right now, I am Director of Nutritional Support at Beth Israel Medical Center for the ICU. We are so pleased, and Karma, take yourself off mute. We are so pleased to have Dr. Karma Warren with us today. I mean, she goes back so many years with all of us, and such an excellent physician over the years. Now she's doing, well, she'll explain what she does, but with varicosities and veins and lymphedema, and there's so many people that have this problem. I thought that we should cover this, you know. And also, she is a ER physician, has 20 years, right, that you were in ER.
Yeah.
So, the emergency room. So what we're going to do is we're going to start off with varicosities. We may get to lymphedema and everything else that you want to talk about, Karma. And then we're going to jump into some ER stuff, you know, why you should go to the ER and what's going to happen when you get there, and will the doctor be nice or he'll sit me in the corner and I have to wait for 5 hours to be seen and all of that kind of stuff. So it's all real, but we need to talk about it. We need to talk about it for our people. We need to talk about it because, you know, you have to understand medicine, medical care, you know, the different entities of medicine and how to negotiate, you know, hospitals and doctors' offices. So that's important. So we need to talk about that as well. Karma, what I'd love to do and have you do is just give us a kind of a short, brief understanding of how you got where you are as a physician. You know, we all have our stories. I know I have my story, and it's up and down and over and under, you know what I mean? And somebody had to smack me up the head against the head and say straighten out a couple times, but I got here. But just for our youngsters out there that may be interested in medicine, tell us how you got where you are because we're so proud of you.
Thank you so much. I'm really glad to be here this morning to just share some information that may change lives and just may help everybody to get a little bit mobility in their life. But I will say, my history is also a roller coaster as well. Growing up here in Newark, New Jersey, I went to Science High School. So I already had that science and math love. And matter of fact, I graduated Science High School with one of your Dr. Kareem Salam. We went to high school together. And so I went to Tuskegee University, but not for to be a physician, but to be an electrical engineer. And so I studied electrical engineering and actually graduated in engineering and worked in the corporate world for about 4 years, all the while taking those classes to get into medical school because I knew before I even graduated college that that was something that I wanted to do. But I didn't have the requirements. And one of the things I always find that is so enlightening to people that most don't know is that you don't have to major in science and biology to go to medical school, but you do have to take the requirements. And so sometimes you can be an arts major, but you took the required courses to get into med school. And that's what I did. So I went to University of Michigan. I did my course classes to get in. I took the MCATs and I went to Robert Wood Johnson Rutgers Medical School. And while I was in medical school, I loved everything. So I liked ortho, I liked psychiatry, I liked GI, I liked medicine. Well, I didn't like internal medicine much. I didn't like the rounding. I will have to say that. But I did like the aspect of everything. And so I kind of felt like emergency medicine allowed me to bridge a little bit of even my background with engineering, in which problem solving is so big, but then also having the opportunity to bridge every aspect of medicine into one. So I chose emergency medicine, and I did my residency at Beth Israel, where I met many of the physicians that are also in your group, and also my uncle Kenny, who's also a godfather and a guide for me and a mentor. But what I learned was how to take care of my people, and it made a love for me to be in that community to educate. And so I wanted to stay in that community, whether it's Newark or abroad, the same type of community in which we have low access to care. So I did my residency at Newark Beth Israel, and then from leaving there, I went to University Hospital, which is obviously the mecca of everything. And I was in the ER there with residents and students for 18 and a half years. And then I had a mentor that said to me, Karma, it's time for you to kind of move off of this craziness in the engineer and the electrical, in the emergency world. And why don't you look at what I do? And I said, no, I don't know. I'm okay. But he pulled me along, and I have to say that's another one of your group members, Dr. Um, Jordan Garrison, who pulled me aside and brought me into his world. And so, in that aspect, I was kind of trying to figure out what would be my place in this world of phlebology, of learning how to take care of my people, but still feel like I was giving back. And so, what I realized is that being a part of this world and the venous disease world, I was still able to educate and to teach my people about learning how to take care of their bodies, but focusing more on increasing the mobility for them. And so I started working in phlebology at Vetral Vein Centers, and now I'm there.
Excellent, excellent. You put that together so well. I could have listened to that for a little longer. Good gracious, that is excellent. Let's step back just for a second here, and we're going to talk about now. I want to let you guide this because
Okay.
I know that we're going to talk about varicosities, but there are other aspects of the lower extremities that you probably work with as well. Why don't we start off with varicosities? The basic thing is, what is a varicosity? It's a big word and it's a fancy word, but what's happening there in the veins that we call that's causing all of this?
I think what's important is that everybody kind of focuses on, oh, I have varicose veins, or they think about the visual aspect of what their legs look like, but it's really what's happening inside the leg. And it's called chronic venous insufficiency. And what that means is that your veins are not acting right, not pushing all the blood back to the heart in per se. So inside every vein, they all have valves. We all have valves, whether the vein is small, large, big. And the purpose is to take this deoxygenated blood back to the heart. So we need to get everything going unidirectional back up. And what helps us do that is these valves that are inside of all of our veins. Right. And so every time the heart beats, the blood goes back to the heart, but these valves close tightly. We have factors in our lives, whether it's we gaining weight and we're overweight. We have family components. We have jobs that require us to stand up on a regular basis or sit down without making us move constantly. We also have, our diets, our comorbidities, and it causes these veins inside our legs to start getting large. These are veins you don't even see. You're not even focusing on what's happening on the inside. And so when that happens on the inside, these veins become varicosities that you don't see, but they cause pressure to build up. That pressure builds up within our veins in our legs and causes the veins to pop out, causes inflammation, and also causes discomfort in the legs. Now, that discomfort can range from anywhere. It can be leg tiredness, heaviness, achiness, swelling, cramping, Charlie horses, restless legs, itching. And, a lot of times we as a people that have jobs that require us to do a lot of service activity, we tend to equate the way our legs feeling tired and achy is just that I've been up all day long on these legs. And so actually, those are also signs that you can have this chronic venous insufficiency. And so the key is that most people get focused on it because they see these veins popping up on the outside and they say, I have varicose veins, which just means that the valves inside of those veins aren't functioning very well and causing engorgement and enlargement of the vein.
Excellent, excellent. I know how the body is put together in the lower extremities. Are these veins the same as the veins? I know that we have deep veins and peripheral veins or shallow veins, veins that are closer to the skin, I should say, for the general public. Which does it? Do you get a chance to evaluate the veins on the inside as well? And do those veins have valves as well? Are all veins the same? And what actually allows us to push the blood up through these veins? You know what I mean? Is it
So that's
walking?
a great
Is it
question.
putting them up higher than our head or higher than the heart or whatever. You give us some idea of the different types of veins and how can we get this swelling to go down?
Well, that's a great question. I think a lot of times, even when people come and see me, they think we're working on, okay, well, there's levels of veins, right? The deep veins. The deep veins are the veins that are really directly innervating and taking the blood away from the organs themselves. And then you move to the superficial level, which are connected to the deep veins, but those are the veins that are right, a step above the deeper veins. Okay. And then you have the veins that you see on the outside. And those are the veins that most people say. So you go from outside in all the way up to the heart. Every vein has a valve in it, but it depends on how many valves they have. Some have 2, some have 3, some have none, actually, one has them. So basically, we're working on the veins that are not the deep, but are the superficial level. And that level includes veins that are right underneath the skin layer to right above the skin layer. And so the purpose is to get all of this blood in this pathway from the out in up towards the heart to be oxygenated and back around again.
Mm-hmm, mm-hmm.
And what helps to do that is activity. That's one of the things that I really kind of focus on really with my patients too, is activity. I know we all, say 150 minutes of activity a week, but really that contraction of that calf muscle is so important. It brings back 2/3 of the blood back to the heart. Then you have the thigh muscle, and then you have the foot muscle that does the other third. But I'm saying it's so important for activity to get that blood back, because that helps when those valves are malfunctioning to help get that blood back to the heart. So activity is really, really big.
So let me get an understanding here. I'm gonna take me back to when I used to do the Moment in Medicine TV show. I'm gonna break it down just what you're talking about is that because the muscles in the lower part of the leg are contracting and relaxing and contracting, that's how the blood comes back up to the heart?
That's what helps get that blood back to the heart. And that's why it's so important. And that's why you find those who have decreased mobility, whether it's maybe they had an accident and they're not moving or walking and compressing that calf muscle, to women that are wearing these high heels all day long, in which they're not compressing that calf muscle, they tend to have a lot of issues because they're not having the most mobility.
Interesting. I guess, yeah.
And so when you're standing on your job and you're serving and you're not moving around, you're just standing there. You're not getting that blood back to the heart.
I got you. What are some of the things that and I'm going to open it up to the panel to see if they have any suggestions or ideas or questions. But what are some of the things that once you see this person, what type of studies do you do, or is there any bloods drawn, or is there any, what exactly, how do we diagnose it, number one? And number two, once it's diagnosed, how do you start your therapy? Is it just basic stuff first and see if they go away, or right away because that one's just so big, that's not going away. It looks ugly. It's always going to be ugly until I do this. It's not going to change. Give us some idea of what your day is like.
Well, that's a great question as well. I think it changes based on the patient. But I will say, for the most part, the way that I start off analyzing what's the best way to take to the patient is their history. First, I find out what exactly do they do, what's their occupation, what kind of symptoms are they having, what family component they may have they been pregnant and released hormones that maybe have caused issues with the veins getting large as well. So I have a history, which is important for me to first work off. At that point, I say, this is somebody who probably does have some risk factors for what I may think may have some chronic venous insufficiency. Then at that point, I find out, have you ever done compression stockings, which is very good to find out. And I always encourage other physicians to tell their patients, if they have patients that do a lot of standing, a lot of sitting, that they should wear compression stockings, because those compression stockings augment the blood going back to the heart. And that's 20 to 30 pounds pressure. So now the third thing is an ultrasound. And I'm not taking blood. I don't need your blood work. I don't need that. I need to find out exactly what it is. And I think by ultrasound, what we're doing is looking inside the veins themselves of the legs. A lot of times people say, oh, I've had an ultrasound. But most times those ultrasounds are only looking for a blood clot. And although a blood clot is a risk factor for having some of the chronic venous insufficiency, what I'm looking for is inside the vein themselves, one, to see how large they are, because that's obviously going to make an increased risk for why that valve is not working that great. But then I'm also looking at the valve themselves to see how they're functioning. At that point, once I find veins that are fitting the criteria for one, size, and also for malfunctioning valves, in which we call this reflux, right? Because the valve is no longer able to close tightly to prevent that backflow, I now realize that this patient has some chronic venous insufficiency. The treatment for that ranges based on the history, whether they've done something to augment it, whether they're having symptoms, and depending on where the veins are located that I found that are the offenders.
Excellent, excellent. I just want to tell everybody who's listening out there, if you have questions, please type your questions in. So don't wait till the last moment. We're about ready to end the webinar, and then I get all these questions. Put them in early. Let's get those questions answered, okay? Now, as far as other types of treatment, or is there massage, or I know that elevating your legs during the night will help bring them down, but usually my patients in the past, they've always said, as soon as I stand up, it blows back up again. All right.
Yeah.
How do you
Yeah.
handle that? I mean, I understand compression stockings, but how do you handle
Yeah.
that?
Well, at some point, compression stockings get to the patients at the point where the compression stockings just aren't helping the symptoms that much anymore. And that's where procedures that we do come in. Now, everybody gets scared because they're always like, is this surgery? What are we doing? No, we're not doing surgery. We're doing procedures that are done in the office. They are no more than 20 minutes long, requiring you to probably be in the office maybe like an hour and a half at the max, and that's from door in to door out. But what we're doing is, I always make this analogy. You have hundreds of veins and pathways in your legs. Your body loves to use the same ones, whether they're good or bad. You currently are using the bad pathways, in which they're using pathways where valves are malfunctioning. I'm going to do a procedure that closes this pathway that they're using and makes the body automatically reroute to a better pathway. It's almost like a navigation system. You're using a navigation system, you make the wrong turn. What does Navi do? Navi just recalculates and reroutes you to the next pathway. That is the same thing that I'm doing. So I'm actually closing this pathway, not opening, or you're not blocked. Your vein is large. So I'm closing that pathway and making the body reroute to a better pathway in which it's using a healthier vein.
Excellent. Interesting. I'm going to reach out to the rest of the panel. Does anybody else have any question? Oh, Dr. Court.
I do.
And go ahead. I knew it was coming.
Doctor, good afternoon.
Good afternoon, Dr. Court.
Nice seeing you after all these years.
Yeah.
Very, very often patients come to me saying they were told to have surgery for venous insufficiency.
Mm-hmm.
What's it with that? What is
Well,
there
I see a lot of patients from different vein centers that have
Yes.
come to us, and I try to reprogram that wording. It is not surgery, and I specifically say that, but it is a minimally invasive procedure. I say anytime you go below the skin layer, it's obviously minimally invasive. But we leave surgery to the deep veins, and that's where you do something that is whether it's going in and actually taking a clot out, which but we typically do just minimally invasive procedures. Now, these procedures don't require them to take off from work, don't require them to they can drive themselves there. They are minimally invasive. Now,
They talk about collapse in the vein. What is what
yeah,
is that? Can you
that's
explain?
what I mean when I say I'm closing the vein. The vein is large, like I said. So when it's large, that valve no longer functions very well. It's almost like a revolving door. Blood just causes the vein to kind of get engorged. And so what I do is I close that pathway, and I close it by different procedures. One can be by heat, in which we call ablation. Another one can be closed by an adhesive, in which we call Venasil. Another way is through a chemical, which I inject the medicine inside the vein that causes irritation of the vein wall and causes it to close and scar over. All of those are procedures in which I close that vein.
Mhm. I know that Jordan, you had your hand up.
Yeah. This is my mentor here, Dr. Garrison. What do you want to add in there? He's on the phone.
I think he's on the phone.
You know how he does.
Yeah,
Yes.
I know. He rocks all the time. I have a question, Karma.
Yes, sir.
Now, I'm just gonna tell you about because my wife has some varicosities. All right.
Yeah, yeah.
But the thing of it is that you know, she the varicosities, they're noticeable on her legs.
Mm-hmm,
When
mm-hmm,
you collapse these veins,
mm-hmm.
does, does that varicosity, the visual aspect, because that's the whole thing. She's like,
Oh,
I just
yeah.
got ugly legs now because
Yeah,
she's here
yeah.
and I'm looking at her legs and saying they look fine to me, but to
Mm-hmm,
her they like, you know what I mean, not perfect.
mm-hmm.
Does that vein go away to the point where the color or natural color of the skin comes back?
Oh, thank you. That's a great question. No HIPAA violation, so we're gonna act like we didn't hear anything about my girlfriend Rita, but Regina, but we're gonna say
Don't tell her I talked about
I'm
her.
not gonna I'm not gonna tell her. But that's one of the things that I think is the driving factor for a good percentage of my patients that come in is that same. I don't like the way my legs look. Well, first we got to find out, why do your legs look like that? So when I take care of the veins on the inside, does that really change the outside? It helps with those bulging veins, because remember I said you're increasing the pressure, and that pressure is what's pushing the veins out. So a lot of times when we close what has caused that pressure, it allows the bulging to come in. Does it change those spider veins and reticular veins, which are the veins that people get so focused on sometimes? Absolutely not. And I tell them that what's come out is come out. And the only way to change that is by cosmetic on the outside. But you've got to take care of what happened from the very beginning, which is these veins on the inside that have become very large. At the end, one of the veins that we do treat are called tributary or bridging veins. Those are the veins that are connected or kind of feeding what you see on the outside when you see the large bulging veins to the superficial level. And so when I treat the veins that are actually feeding those, it actually kind of does treat the bulging veins themselves. So one, you get a benefit by me decreasing that pressure, bringing in that bulging. But then when I treat the tributary vein itself, then I'm actually treating that also vein.
Mm-hmm. Excellent, excellent. There was a question that came in. Are varicose veins hereditary?
Yeah, absolutely. And that was one of the things on the history. When I sit down with my patients, I try to find out, hey, does mom and dad have it? Does your siblings have it? And so there is a genetic component. With one parent, you're looking at a genetic pass down rate of about 50 to 60%. If you have two parents on both sides, you're looking at a 90% rate. Now, that doesn't mean your legs have to look like your mother or your brother and sister, but there is a genetic component that makes those veins large on the inside. And that's what I'm talking about. Increased risk for you to have the pressure and to have the malfunctioning valves.
Excellent. Dr. Sprott, you have your hand up.
Yeah, Carl, I wanted you to help people understand the normal blood volume and the distribution of blood volume between arteries and veins, the pulmonary circulation and the systemic circulation. And,
oh, I don't want to do cardiac because I don't really know.
no, I'm just saying. Well,
I'm just joking. I mean, I don't go. Look, when I tell my patients, they start asking me questions. I'm like, yeah, I don't do anything above the waist, so I don't know anything. I'm just joking.
So I'll just say, since it's for Omar, maybe Omar can take it, but there's a systemic circulation, which means that the blood comes from the left side of the heart, left atrium, the top vessel, receiving left ventricle, where it goes out into the systemic circulation, and it gets pumped into arteries. And the amount of blood in the arteries is a lot less than the amount of blood that's in the veins. It's maybe about a fifth of the volume of blood that's in the veins. And so there's a large volume of blood in the veins. And again, that blood that's in the veins has already had the oxygen taken out of it. And it needs to return to the heart gradually in order to get to the systemic circulation where you get the oxygen going to the vital organs. My question sort of relates to the issue of if you start to have a larger accumulation of blood, or do you have a larger accumulation of blood in the veins when you have these abnormally functioning veins and the valves?
Oh my God, that's great, Uncle Kenny. You actually said that perfectly. That's the major and contributing factor to why you see a lot of swelling in the legs. And because these valves are malfunctioning, you're having the reverse flow, which also causes pressure within the vascular system of the legs, right? So since we all carry a amount of, for say on a layman term, fluid or edema in our legs, the fluid goes down the pathway of going back into our bloodstream. But if you're walking around with a lot of pressure from these malfunctioning valves, guess where the fluid stays? In your legs, and you start to get more engorgement and more swelling of the tissues around it. So that does contribute a lot to it, especially since the veins carry so much of the blood volume and work hand in hand with our lymph system to try to get everything back to the heart. That is a major contributing factor. Now, because of that, one of the ways that I'm able to really explain to the patient that they come in with a darkening of the skin. Yes, we see that in some of the other disease processes, but because you have deoxygenated blood staying in the tissue so much longer, that does contribute to why you see a lot of the darkening of the skin of the lower legs. And it kind of starts on the inner legs, and then you may start moving up the leg itself. And that's also another example of why those valves aren't working and what you see happening as a after effect of that engorgement of the tissue in the veins.
Excellent.
So part of I was leading you there to a certain extent. But so if you think of the total body, about the vast majority of the weight of the body is in fluid, and 2/3 of the volume of the water is in the cells, and a third is outside of the cells. And so the fluid that's outside of the cells, if you're talking about the lower extremity, is a normal volume of fluid. And part of what you said is that volume of fluid can change. It can increase if there are changes in the pressure in the veins. It could also change if there's not enough protein in the vessels. But when you talk about those individuals whose valves have gotten to the point where it's leading to this increased pressure and a decrease in the amount of fluid that's returning into the vascular system, are the procedures that you're doing helpful in eliminating that edema or that increase in the amount of fluid that's outside of the cells in the lower extremity?
Yeah, that's exactly by decreasing the veins that are causing that or contributing to that increased pressure or changing the pressure. and making the body reuse the veins that to get that more blood back to the heart that way. Yes, that is what the ultimate end product of the goal of doing these treatments are. And
Excellent.
so what I also do with a lot of my patients that have significant amount of swelling and edema is I do a two-part, right? I take care of the veins and that part in which the pressure is coming from these incompetent valves, but I also connect them with certain devices, companies that provide devices that help get some of that fluid back to the heart as well. And that's with the pneumatic compression devices.
Right, right. Explain that. That's a big word.
Yeah.
For the general public, pneumatic compression device.
So they're just air pressure devices that are sequentially significant to how they gradally go up with pressure up the leg to help push that blood and bypass what some of the incompetencies we see within inside the valves to help get that blood back to the heart. And also, one of the things that Dr. Sprott was kind of mentioning and kind of hand in hand with that is that the body has the natural process of pushing everything and bringing everything back to the heart. And so that's when you see the lymphedema and things like that. Those channels get so overwhelmed that they cannot handle the amount of volume that needs to go back. And so these devices help combat that.
Excellent. What I want to do is several physicians joined. I'd like to introduce yourself, and then Dr. Ali, then we're going to take your question, okay? But first, start off and introduce yourself, Dr. Ali.
Hi, yes, Mazhar Ali. I'm a gastroenterologist in San Diego at Scripps Clinic.
All right. I think I caught you first time. I thought you were one of the ones that added. Dr. Jordan Garrison, please.
Good afternoon, everyone. My name is Jordan Garrison. I'm board certified general and vascular surgeon. I specialize in venous disease. And Dr. Warren, I think you're being a little bit too humble in who you are. You know, when we met and we talked about you transitioning into this type of work, you know, you had the aptitude, you had the knowledge, you had the gumption, you had all those things. And this, you know, you should be congratulated on your transition. And I think you are the ambassador to carry forth this knowledge of this disease forward. Very proud to know you, very proud to have been a part of your transition, and look forward to great things that you can do with this entity of venous disease.
Amen.
There we go. There we go. Thank you. Dr. Haniel Rosemont, how are you doing, brother?
How are you this afternoon? I'm Dr. Roseman. I'm the representative from the dental community. I love these lounge opportunities with the doctors and the general public because I increase my knowledge and what I learn on these seminars and have an opportunity to share it with my patients and cross-refer to you professionals as well. So thank you again for having me.
All righty. Sounds good. Dr. Ali, I know you have a question, but keep in your mind, I'm going to ask you about hemorrhoids. All righty. As soon as I thought about varicosities, I'm like, we got to talk about hemorrhoids before this show is over. Okay, go ahead with your question.
Well, then, you know, that's a little bit of an alluding to where I was coming from about this topic as well. You know, varicose veins, those varicosities. Whenever I see a patient with this, I think to myself, well, you know, yeah, you probably should see a vein specialist, and we can fix it. And you know, as discussed, I think trying to find, with Dr. Warren talking about kind of finding the right channels. I guess my question, and we also maybe to also guide our audience as well, you know, we think about two different things though, right? We think about these plump veins, and then there's edema, or, you know, lower extremity edema as well. And I guess maybe I'm wrong to think this, but I think about them as two separate entities, right? Because those veins are particularly larger, and I know that that could lead to one to the other as well, obviously, because you're not getting the flow back up. But then when I think about edema, you know, the first thing I think is, well, should I get this patient? We got to work up their heart. We got to work, you know, as an internist at heart, right? I have to think about, like, and I see a lot of liver disease. So do they have a liver problem? Do they have anything that's causing that? Number one. Number two, do we want to manage that first with a pill, like a water pill? versus going straight to anything like a minimally invasive procedure to fix it, or could they be both done together?
I love that question. A lot of times, my patients have so much comorbidity, and I do not make the assumption that everything that they're presenting to me is just because of the venous disease. It's they have all type of etiologies that are causing it, and so I have to ask the question: have you had that checked out? Has your cardiologist done an evaluation? And sometimes that question kind of leads to, yeah, well, I have this stuff in my heart. Well, I'm not talking about your heart. I'm talking about your legs, but I want to make sure that it's your heart that's pumping well and not causing this backflow of why you're having the edema. So yes, there is multifactorial reasons why people have it. I always tell people this is not an overnight success. Like tomorrow, your ankles are not going to be normal because of what I'm doing. It takes months, and I work hand in hand with your other physicians. And I always make a point to say, don't just schedule a procedure with me that you haven't discussed with your other physicians. And the reason why is because the left hand should know the right hand, and working in the ER for so many years, I'm like, you're on 50 different medications. Does the other doctor even know what you're on? And so I think it's so important that when they come, they know that other avenues have already been evaluated as well.
Excellent, excellent.
Thank you.
Dr. Court, you have a question,
Yes,
please.
I do. For the doctor.
Yes.
We see these patients after they've been treated, they have developed the hyperpigmentation. What's your recommendation in terms of treatment for the hyperpigmentation?
Well, it depends on what you mean by the hyperpigmentation and where it is.
The darkness on the lower
yeah,
extremities.
but where you're saying after the vein that was treated became hyperpigmented? Because if it was a very large vein, you will get hyperpigmentation. I mean, that's part of the process. What we do find is that melanated skin sometimes gets a lot more hyperpigmentation than it does their skin. And so what we try to do is we try to not have the strongest percentage of medicine in which we're treating that. But hyperpigmentation is part of the process of the healing. It just is the last part that kind of sometimes does get better. So the first thing is the vein will, if we're talking about a bulging vein, let's say that per se, the larger the vein, the larger it is that's going to have some type of hyperpigmentation. Now it will get hard. I basically scarred over the vein on the inside, and then the body kind of just, in the easy way, eats it up from behind. The last thing that ever gets better is the hyperpigmentation, and that takes months as well. Another thing that I do with some of my patients as well, if the hyperpigmentation is staying for quite a while, is to tell them you can put some glycolic acid on it, Dermica, different things that we kind of not prescribe, but encourage they can use if they don't want to wait that time to help expedite the process. But that is also part of it. And I make sure that the patient knows that from the very beginning.
It's like a skin lightening cream.
It helps with the lightening. Yes, sir.
Excellent, excellent. Dr. Garrison.
If I get long-winded, Omar, cut me off, please.
Okay, is it possible?
All right, stop now, because he's already.
Just a little bit. Is it possible to turn your volume up just a little bit, if possible?
All right, how's that? Is that better?
That's better.
That's better.
Just to put a lot of what Karma is saying in context, when I did my residency and I was at the VA and we were on the vascular ward, 95% of our energy was spent towards arterial disease, meaning the flow of blood. That was the sexy stuff. 5% of the time was dealing with venous disease. And that's a lot, to say a lot. It's like, okay, somebody came in with problems, venous problems, put some wrappings on them, tell them to come back in a month, tell them to elevate their leg and walk a lot, all the things that Dr. Warren is saying. But as time has gone on, we found out that venous disease is a separate entity, and 30% of the American population has this problem. And not only is the population undereducated, also our physicians are undereducated about this disease. And as Dr. Ali was saying, we can break it down into things that are purely venous disease, and we can break it down in things that are coming from other causes, from cardiac disease, from liver disease, giving rise to edema. The edema in venous disease is because of the reflux in the incompetent valves. And Dr. Warren went into why those valves become incompetent. It's a DNA predisposition in people to have incompetent valves. There are other factors, obesity, that causes increased pressure in the valves, which therefore make the valves incompetent, and therefore you get the reflux. Dr. Court just asked about the staining that comes from. The staining comes from the leakage of the pigment in the blood called hemosiderin. Dr. Warren also said it's compounded by the deoxygenation of that the venous flow or reflux prevents oxygenation of those tissues. So you have two compounds coming there. So essentially, the blackness or the darkness of the skin is a tattoo from the hemosiderin that has leaked into the tissues. And it's very, very hard to get rid of that tattoo. It's a lot of, now we can use these things like glycolic acid, again, what Dr. Warren talked about. But the return to normalcy may never exist. But what happens is the function and the symptomatology improves with these procedures that we do.
But
So,
also the melanated skin, they tend to stain more. And then also those veins that are extremely large, they tend to have more, which makes sense. They have a lot more blood volume in them. So obviously they're going to have a lot more hemosiderin in it. But yeah, go
so
ahead.
so part of our job is not to educate the patients, and the community, but also to educate the physician about this problem. And so we find a lot of people that are undertreated. Even some of the older surgeons feel that this venous insufficiency, you should take them to the operating room and do these extended procedures on them, which are like crazy. I remember going in doing something called the Linton procedure, where we tied off all these veins individually, and it was 3 to 4 hours in the operating room, still with limited results. So again, Dr. Warren has talked about the approach that we have, and the biggest tool that we have is an ultrasound and looking at the amount of reflux. And there's a criteria of 500 millimeters of mercury per second, and the size of the vein, 3.5. If you don't fit into that criteria, what we're doing, if we were to do surgical or these procedures on them, it's going to have minimal results. We also have to delineate the superficial system from the deep system, and that's what the ultrasound will show. And as she was describing the system, look at a tree that is upside down. You have small branches going to bigger branches, going to truncal branches, et cetera, et cetera. What we do is work on the superficial branches, the ones that you see and the ones that are 1 to 2 centimeters below the skin line.
Let
And
me
that,
just let me just let me just say something before you move on. I think it's so important as physicians that we kind of understand this. I did emergency medicine for 22 years. And I don't even think one time I knew anything about this. And to the point where if you came to the emergency department, only thing that I cared about was whether you had a blood clot or not. You don't have a blood clot, you're good, go see your doctor. And now when I do treatments, I ask patients if they go to the emergency room, I have the doctor call me because they really still don't even understand what we're doing, to the point where when they come there, they see this closed vein and they're thinking, oh my God, her whole vein is clotted off. I just had a patient admitted the other day to Beth Israel, and they thought that her vein was closed off for the whole leg down. And I'm like, no, they had her on IV heparin. And I'm like, no, 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 no. I treated that vein. It should not have flow through it. So she's there because she has cellulitis that has nothing to do with this vein that you saw all the way clotted all the way up. And so it's so important. I think that's not really part of our medical education, maybe, and since we should probably put in residency education. But I think it's so important that 1 out of 3 people have this disease process, and it's not really part of our education as physicians.
and going on with this, so when we treat and your points are so salient, Karma, that we have to educate not only the patients, but we also have to educate the physicians in their lack of knowledge of what this disease is and what we do as well. And that's part of what I am doing now in the educational process. Dr. Ali was talking about hemorrhoids, and we can get into that because what we're finding is that these treatments for superficial veins have other wide consequences that we can treat other diseases. Hemorrhoidal disease, we can treat prostatic disease, we can treat ovarian diseases, and these are the things that I'm doing now in learning how to treat those diseases and championing those treatments for these diseases. For, men have prostatic problems. We don't have a urologist here, but treating the prostatic veins with venous ablation has shown tremendous progress in dealing with the amount of time that men spend urinating, the waking up at night urinating, and all
Well,
those.
I'm gonna say I'd like to just stay on the legs. I don't want to do anything like that.
Well, that's what I said. You're a great ambassador for that
I
disease.
don't want to do that.
If you've taken the mantle from me, they don't need me anymore.
I don't need that.
So
I don't need it.
you the guy. You it.
Nah, I pass.
Okay.
I'll gladly take the rectum.
Okay, thank you. You're it. I'm not doing that.
So I just want to let you know where we're going with this venous process. But there's tons of patients. 1/3 of the American population or the world's population has this. It's underdiagnosed and under treatment, and that's why we need folks like Dr. Warren in here champion it. So go ahead, girl.
Thank you.
Sounds good. Sounds good. Dr. Sprock, you've been patient.
I think I'm going to go back to Dr. Ali's question in terms of this whole issue of edema and an evolving process.
Mm-hmm.
And so, when I talked before about interstitial fluid, and the volume of fluid surrounding the cells is constant. And it's constant, but it is an active process, so that the fluid is created as the heart pumps and the blood goes down into the smaller part of the arteries, and fluid gets pushed out. Now the cells remain in the vessels, but the fluid gets pushed out, and then the fluid returns, and it returns either via the venous system or the lymphatic system. And the reason that it returns is because of a larger volume of protein within the vessels, and there's no protein in the interstitial fluid. And so that's an oncotic pressure gradient that's created that allows some of the fluid to return back into the venous system. Now, what we're talking about in this venous insufficiency is a problem with a back pressure. An accumulated volume in the veins creates a certain amount of pressure that impedes the flow of the fluid back into the venous system. Also, as Carmen talked about, the lymphatic system, which is doing more work than it normally does, gets overcome. And then you start to accumulate a larger volume of fluid surrounding the cells, and we call that edema. Now, the salt content in that fluid is the same salt content that's in the entire vascular system. So anytime you have edema, it means that you have an abnormal amount of salt, an increased amount of salt, which is why people talk about trying to give a diuretic, because a diuretic is used to sort of get rid of salt. The water follows it. But if you've not changed the dynamics around why it was created, you'll never be able to catch up by using diuretics. Because as soon as you get out that salt in the water, your kidneys are going to say, there's not enough volume in the arterial system.
That's right.
I need to reabsorb this salt. And you create this vicious cycle. Okay. Now, when you have this larger accumulation of blood in the venous system, as Karma said, that blood is deoxygenated, which means there's a bluish discoloration. Okay? And so there's and along with this, if you have enough of it, you'll also start to have edema. But if you have enough of it, you also will start to damage the small capillaries that are around this. And there you'll actually leak blood from the vessels into that interstitial fluid.
That's right.
And when that blood is there, that blood breaks down, and that gives you that hemosiderin that Dr. Garrison talked about. So when the blood vessels break down at the capillary level, there's blood leak, not just fluid, blood. And that blood, when it gets destroyed, remains in an interstitial fluid. And unless you remove that hemosiderin or the iron that's sort of left there, and the way that that usually gets removed is via the lymphatic system, and the lymphatic system is already overwhelmed, then it takes a very long time to get rid of that because there's no efficient way to remove that interstitial fluid. So you have this sort of gradient of the distended veins, edema, breakage of capillaries, blood leakage, to create this whole system of things that I think if you recognize it early enough before you start to get to that point, you might be able to prevent it from happening. So I think to a certain extent that given the number of people that have this stuff, the earlier you might address it, you might be able to prevent a number of these things that occur consequently. And so if you come in, you already got discoloration, which probably means that you have breakage of capillaries. You've already gone through all of those processes already, and it's going to take a lot longer time to cure something like that than if you address it early. Yeah. And if indeed you have a question about it, if you can go to these specialists and they can actually do these ultrasounds to look at what's going on and address it before it starts to get so bad, I think a lot of people would be better off.
Yeah.
Thank you, Dr. Spratt. I think you explained that very clear, and you broke that down on a microbiology level. But that for us means that when that patient presents that way, they are farther along in chronic venous insufficiency than most of the patients that. So at that point, their level, when we are actually grading the amount of disease they have, puts them at a much higher level, just for the simple fact of what you explained.
That's why I'm giving you a commercial that folks need to go in a lot earlier to prevent those things from happening.
Definitely.
To what you're saying, Dr. Spratt, what I hear is you're advocating that because by the time, as Carmen said, by the time they see us, when we rate these on a SEEP level, SEEP score, they see us at they're like a SEEP 3, 4 out of 6. Whereas the primary care doctor, they'll come in and say to the primary care doctor, my legs are tired. I got cramping. I got restless legs at night. If that is not recognized as the harbinger of venous disease, then that opportunity is missed. So what we have to do is educate our primary care physicians, our cardiologists, our internists, and our GI people, that when patients complain of these symptoms, then that's when the referral needs to happen. And this is exactly what I think you're saying, is we need to get to them earlier than later, and therefore we can prevent.
What I'm trying to say is that the fact that one has varicosities, I think, is sufficient enough and early enough for you to get an evaluation to see whether or not you need to have anything done or not. Because they start out with these varicosities, these veins get enlarged. And even though that they're not causing you any pain or anything at that point, it might be an opportune time for you to have an evaluation to see what's just going on superficially might be going on deeper, and you might need to have something done.
Well, I think that's good. I definitely agree. But I will say this, for insurance to cover, no matter whether they have disease on the inside or their visible veins on the outside, discomfort, and that is very important for it to get paid. So they may need treatments or want treatments, but insurance is not going to pay that $3,000 bill unless they're having some discomfort or heaviness or tiredness or some of the symptoms that I talked about, because they could care less about how your legs look on the outside.
Dr. Warren, I suggest to you that almost everyone that comes in at that point, you encourage them to have discomfort.
That's not true. That's not true, Dr. Spratt. You might believe that.
You're not hearing what I'm saying. You need to encourage them to have discomfort so that the insurance will pay.
Nope.
I'm not going to jail for lying.
Don't go there.
I'm not doing that.
Don't go there. All right. Dr. Duncan, your hand's up. Well, thank you for being patient.
Thank you for being so patient, Matt.
Sure. So, first and foremost, I'm sure you're wondering why I'm commenting, because it is
No, of
psychiatry. But
course.
today, really emphasizing, mental health is health. So the reason I'm saying that is actually, I want to shout out Dr. Garrison talking about knowing the signs. So one of the big, a common complaint for us in psychiatry is poor sleep, and patients will want, trazodone, some kind of medication. But a lot of times, with regard to why they're not sleeping, can be because of symptoms of venous insufficiency. So this is feeling particularly uncomfortable with your legs at nighttime, swelling, etc. Some new studies that are out now are actually showing correlation of new onset depression in individuals who have a varicose vein. So it goes two ways. Certainly not going to be the person to diagnose, venous insufficiency or varicose veins. But it would be important, or it is important, with regards to patients you're sending them to go get sleep studies because they're saying their partner literally wants to punch them in the face because they're snoring all night. Or, they literally come in and you're seeing how swollen their ankles are. You are seeing that they say that their legs are hurting when they're walking, etc. And it really sounds like they do need to follow up with primary care and then a specialist. And that is important. Additionally, it goes the other way as well, where there is a mood component of this. And these kinds of symptoms, and as everyone's talking about the way that your legs may look, etc., brings distress, and because of that, it can really play on deteriorating somebody's psychiatric or mental health as well. So just wanted to comment and bring that
No,
to
that's a really great point, Dr. Duncan. I think part of our history, what we're getting from patients is, I can't sleep all night. I'm waking up all night long because my legs just constantly want to move, or I'm having these Charlie horses, and I can imagine that would play on their psyche. Part of that is because the body is so amazing. The body knows that the calf muscle will push a percentage of that blood back to the heart. So the body automatically responds to that and says, contract the calf muscle. So that means while they're sleeping, the body is move your legs around, because I know by moving your legs around, I'm going to get some more blood back to my heart. So you are at night, can't sleep because your body's responding to what's happening inside your veins.
So Matt, what you're saying is that the reason that Donald Trump is so crazy is because he's got venous insufficiency. If we correct his venous insufficiency,
well, we saw his ankles, so we already know he has some venous insufficiency. We already know. We saw that picture. We're like, oh, I'll take him as a patient.
I'm not going to violate what is the Goldwater law that psychiatrists are supposed to follow. What I would say, the only thing that I'm going to say is Congress has now asked that he get a cognitive evaluation.
Oh, really?
I don't think that is wrong. And that's all I'm going to say with that. So
okay, Dr.
Oh boy. So it's starting. It's starting. That's good. That's good. Matt, thank you for making that correlation, because I know with obstructive sleep apnea, definitely is a component of restless leg syndrome and stuff like that, and obesity.
Absolutely.
I think, the way I look at the body, it all works together.
It does.
There's no part of the body that's not affecting the other part of the body. And, when we're pulling it all together, it's just one big mesh. Everything's associated, so everything's affecting one's. Somebody had their hand up, and
I did. This has been an amazing conversation, and it's kind of leading to so many other things. But I guess the bottom line for a patient coming in, swelling in the legs, veins are up, whatever it is, it sounds like the thing that they need to advocate for, really, from what you're saying, is, they need an ultrasound of their legs, right? And that ultrasound will help us look at those veins to see if there's something else in addition to, maybe this is from high blood pressure, maybe this is from heart disease, maybe this is from something with the kidneys or the liver, but there could be a two-hit thing going on from what you're describing, right? And it's almost like an enlightening moment for me, like, hey, there's like a 1-2 hit situation here, and that's why this is happening. So we should be looking at those veins. And is that just a standard ultrasound that the patient should be advocating for? Is it a special kind of ultrasound? And is there particular criteria as anybody that would refer to you, right? What do I need to see there to say, oh, you know what, you need this kind of procedure because that criteria right there is off?
I would say the ultrasound should be from us. Refer them to a vein specialist, because the ultrasound that you generally do is just for blood clots. And so we are doing a little bit more than that. So if you have patients that have swelling, aching, heaviness, cramping, restless legs, itching, tiredness, send them to a vein specialist so we can see if something is happening inside those veins that we need to take care of. And that will include the ultrasound.
You know, also what we should do also is talk about venous problems where you do have that clot, and which venous what part of the venous system do we worry about if it gets a clot? Because the superficial veins, understand those veins, even if they get a clot in them, it's usually not the veins that cause what we call pulmonary emboli, or a piece of that clot flicking off, going up into the right side of the heart and going through the right side of the heart and getting stuck in those pulmonary arteries or those lung arteries that can be so dangerous and life-threatening. So that's not that's not part of that superficial vein clotting that we're talking about today. I think that should be recognized. It's 2:10, and right now what I need to do is my excuse me, second half announcements, and then what we'll do is we'll introduce each of us again. And then there may be some things that I'd like to shout out as well. Those that have their hands up, please keep them up and we will get to you. But let me do the second half announcements now. What we're going to do is introduce the doctors first. Dr. Sprott, can you introduce yourself?
Kendall Sprott, retired pediatrician, did critical care pediatrics and general pediatrics.
All right, thank you. Dr. Court.
That's James Court, internal medicine, East Orange, New Jersey.
All right, Dr. Anderson.
Hi, it's Patrick Anderson. I apologize for getting in on the second half. Dr. Court beat me to it. We both were rounding, and the old guy got out faster than I did. But happy to be here. Second Saturday of every month. I'm a GYN oncologist at North Bethesda Medical Center.
All right, thank you. Dr. Garrison, please.
Good afternoon again. Jordan Garrison, board certified general vascular and bariatric and venous surgery. And presently my practice deals with diseases of the venous system.
All righty, thank you. And Dr. Carmen Warren, please.
Dr. Carmen Warren, board certified emergency medicine and certified in venous and lymphatic medicine.
All righty. Dr. Duncan.
Hi, everyone. Matt Duncan, fourth year psychiatry resident, Ocean University Medical Center, starting as a addiction psychiatry fellow at University of Pennsylvania in July.
All right, thank you. Dr. Ali.
Hi, Dr. Mazhar Ali, gastroenterologist at Scripps Clinic in San Diego, California.
All righty. And Dr. Rosemont.
Daniel Roseman, representing the dental community, and I'm in South Orange, New Jersey.
Now, Hanny, I know you can put some dental flair into this. I'm going to get you in there somehow, some way. You know that, right?
I'm looking for opportunities. I'm in.
Okay. And I'm Dr. Omar Bey, retired pulmonary critical care physician. At this particular point, I am Director of Nutritional Support for the ICU at North Bethesda Medical Center. What I'd like to say is that every second Saturday we are here, and all you have to do is tell people to go to OBHealthy, hit the doctor's tab, and come in. It will guide you through to the webinar, and please just put in your medical questions. As far as past webinars, you can go to the website and just hit the YouTube sign. all of our past webinars are available. I'd like to say the most important thing that I can say throughout this webinar is please do not change any aspect of your medical care until you consult your doctor. Only your doctor can truly take care of you from a medical standpoint. All righty. And I'd like to thank OBHealthy for allowing us to use their platform so that we can bring this webinar to you. Thank you. Dr. Kenny Sprock. Before we do that, Dr. Warren, there was a question that came up some time ago. What causes spider veins?
That was my question.
Well, I mean, I actually kind of alluded to it earlier, but once you start to have the chronic venous insufficiency with the increased pressure in these veins on the inside, remember, all veins are connected, no matter how small, how big. And you start to get the pressure that starts feeding and pushing these veins out on the outside that you see. It starts off a little small. Sometimes they get large. One of the things people see these little small blue veins near their ankles and their feet. Those are an extension of the increased amount of pressure that's happening from those veins that we are analyzing, having the valves not working that great. And so it's because of what's happening on the inside. Now, there's also in that genetic component that adds also to that as well. Some folks have that genetic component that's pretty strong.
Is there any treatment for that, doctor?
Yeah, so it's just so there's also a small percentage of patients that don't have the chronic venous insufficiency on the inside that are causing that, right? Or because they've had the chronic venous insufficiency for a while, they have these spider veins, these reticular veins. When I say reticular, it just means the veins are a little blue and they have more blood flow through them. So they're a little bit larger in diameter and the roundness than they are for the small spider ones. And so we do cosmetic treatment for those. And that is when we actually inject medicine inside those veins. And the goal is for those veins to get lighter. I will tell you right now, no matter what you see on a video or social media, they are never going away totally. Okay, they will get lighter. And what we try to do is treat them by giving a medication that we are doing that will cause those veins to collapse and to get lighter over time. And on general, people do about 3 to 5 treatments on those to try to get those a little lighter. Now, this medication also can cause hyperpigmentation. And a lot of times we do see that in melanated skin a little bit more.
Excellent, excellent. Dr. Sprout, your hand.
Yeah, Omar, you commented on blood clots forming, and one of the primary issues for the formation of blood clots within vessels is certainly if there's injury to a vessel, then there's a tendency for the things that cause the blood to coagulate or to stick at that point is a fact. But just decreased blood flow in general is something that predisposes one. So if people have surgery and they're recumbent, they always try and get them out of bed and walking to move things along. Because if you're just lying in bed, recumbent, then the blood flow is slow, and you're more likely to have a blood clot if indeed there's decreased blood flow. And so when you have, and I go back to the varicose veins, this is sort of evidence of venous insufficiency, which means that there's decreased blood flow. And so there is a tendency for clots to form. But indeed, I think that if indeed you have varicose veins, Karma and Jordan talked about the insurance companies. Insurance companies don't want to pay for anything that's cosmetic in nature. If it's just cosmetic in nature, they don't want to pay. But if indeed you have sort of venous insufficiency, and that's what it ought to be called if you have varicose veins, you can do the compression sleeves, which is what Jordan, they used to tell you when you first were a resident. If you fail to have improvement over 3 to 6 months, then insurance companies will usually pay for something because you failed to respond to that.
No, yes and no. So just because we find on the ultrasound that people have dimensions that you would say, yes, we would treat. Again, it actually comes back to what a clinical picture is. And so you would think that they would care that they have these large veins that predispose them to probably have some type of decreased flow with increased risk for hyperpigmentation, DVT or SBT and so forth. No, it's still a big factor on what they clinically are feeling. And they will not pay for that. Unfortunately, no. So it's about a clinical picture and how the patient feels, not always just the fact that we find it on the ultrasound.
Mm-hmm. Excellent.
It's unfortunate. And maybe in the past, and I'll tell you, well, I'm sometimes in the middle of the treatment. The insurance companies are changing every day on what they want to pay for.
I know, and I consider it to be, organized crime in some situations. But you talk about educating physicians to make these diagnoses early. The insurance companies need to be educated too, because there are serious complications that can develop.
We know. I had an argument on the phone with the doctor from United Healthcare recently. I mean, I constantly, I would say 3 times a week, I'm on the phone with the physician from the insurance companies trying to educate, but they create policies sometimes that it's only about financial monetary holdings for their company. I mean, like you make a requirement that now I can't treat the patient. I will never be able to meet that. That makes absolutely no sense, but they don't care. They don't care about that.
Mm-hmm, mm-hmm. And they make it seem like you're the bad person.
And they make it seem like I'm trying to just make some money. What do you mean? The patient's having discomfort. We're like, what do you want from me? But now you put in a requirement that if I did what I was supposed to do from the very beginning, I would never be able to meet that second requirement. So it's just, it's not good.
Yeah, and part of the problem, they move the cone all the time.
They move the cone constantly.
Right.
Yeah.
Once you comply, then they keep adjusting.
Yeah. I apologize to my patients on a regular basis. Like, hey, they just changed the policy yesterday, so no longer can I do this treatment for you. I mean, it's crazy.
And none of it is ever founded on data. Good, hard data.
Never. Never.
I disagree. They clearly understand that how many denials results in how much money that they're able to save. So when they're moving the post, they've done the data. They know exactly how many calls they've gotten. They know exactly how much they're going to save by denying it. So they have the data, they have the AIs, and that's how they're able to move it to say, okay, we're going to save this amount more money so that the executives get X number of bonuses.
So well, I mean, data is in medical data.
Clinical data,
not medical
right.
data.
We're not talking about financial data, but yes.
I data guidelines. What his question was, but I just broadened it to financial data.
Yeah,
that's what it's about.
It's
all right. Excellent. Patrick, your hand is up, and I know you have something interesting to say.
Yeah, so just, one is more of a public recommendation question to Dr. Warren, and the other one has to do with therapy. So Dr. Warren, so people who may have or may be older or may have cardiovascular disease and they look to travel on tours on long distances, are there recommendations that you can make to prevent some of these issues surrounding poor venous systems?
Yeah, thank you, Dr. Anderson. Good to see you. I definitely, and not just I call seasoned patients, but also my younger patients that tend to be on these long flights or traveling where they're sedentary for longer than 3 hours, they should be wearing compression stockings. And they should be medically graded compression stockings, not just the compression stockings that are the same pressure of the whole leg, but it should be a stocking that they can tolerate putting above the knee. That should come to mid-thigh, at least above the, and it should be 20 to 30 pounds. If not, at least 15 to 20 pounds pressure graded as it goes up. And what it does is it augments and helps get that blood back to the heart so that they're not as vulnerable to these large veins or incompetent valves in the veins that would increase their risk for having some more edema and blood clot.
And then the other question is the use of pharmaceuticals prophylactically prior to travel. And my other group of question has to do with lymphedema therapy in patients who may have idiopathic lymphedema or lymphedema induced due to some of these cancer surgeries I do, chemotherapy, lymphangitic spread of some of these cancers that we treat.
Yeah, first of all, we all know lymphedema, and even now the lipedema or lipedema, sometimes people are pronouncing, those are so very hard to treat. And it really takes a long time and a long process of getting these overwhelming channels not as overwhelmed, and also getting everything back to the heart. I mean, it's also, for me, I don't have any therapeutical medical medicine that I'm saying that they should take. But I actually promote continuing with those compression stockings regardless, and then taking care of the venous disease as much as I can do to help with that lymph system overflowing and overwhelming.
Mm-hmm. Yeah, yeah. Do you find that associated with cancer, Patrick, or how do we?
Yeah, so if you look at how over time we've gone ahead and staged these cancers, you go back 20 years when we do these surgeries, we would do what we call radical lymphadenectomy. That approach has somewhat lost its way because now over time we've used different systems, whether it's using radio-labeled activities to find potentially involved lymph nodes, or we use certain dyes that has a predilection for involved lymph nodes. So we tailor the lymph node dissection to the areas that are most likely affected. So as such, we don't remove as much of the lymph nodes and the lymph channel. And from a surgical perspective, we decrease the number of lymphedema complications that we've had when we do some of these extensive pelvic surgery. However, in patients with progressive disease, we often rely on, the cytotoxics that we use and some of the immunotherapy drugs that we use to treat these cancers and to some extent limit the lymphedema in that way. But, we still struggle with a good 30% of patients with chronic lymphedema as it relates to cancer treatment. Mm-hmm. And then the other component of it, and I'm not sure if Dr. Garrison and Warren has seen this, is dealing with the neuropathy that comes with it. And we often think in a singular way, neuropathy is just nerve, but I know some of these vascular structures do have neurologic support. So when we affect the impulses to veins and arteries, I'm sure we increase the compliance of some of these vessels from a neurologic perspective, and I'm not sure how that impacts the lymphedema, well, not lymphedema, but the venous insufficiency that they often have to deal with.
Mm-hmm, mm-hmm. Good question. Good question. Dr. Sprock, you have your hand?
Yeah, quick question. There are a lot of advertisements and commercials that tout copper for the compression sleeves. Any medical evidence to show that copper is any better than just plain old elastic in terms of compression sleeves?
I haven't read that. How about you, Dr. Garrison? I mean, I see a lot of those ads. Sometimes my patients have, but I haven't seen the literature as far as my education that shows the copper to be super helpful over just wearing the compression and the proper amount of pressure to the legs. But getting to Dr. Anderson's question too, part of the sometimes you do see patients that have the neurological complaints, whether it's some numbness, tingling in their legs. And quite frankly, I tried to make them understand that I don't think that's the major issue, but I think because of the structural pressure on nerves in that area with the edema, that is contributing to a lot of the symptoms that are coming from the numbness, tingling that they have, but not necessarily the major reason for why they have it. But yes, we do see that. And sometimes when you're relieving, obviously, the edema or helping to get some of that retention back to the heart, that collection back to the heart, that is making some of that feel better.
Mm-hmm. Excellent.
Dr. Spratt, I think the copper conversation is an interesting one, right? Because it primarily is supposed to be an anti-inflammatory type of influence, right? And, from what I remember, even, just going to the market with my grandmother when I was young and had no idea what copper was, I used to see people selling copper bracelets.
Yeah, they were selling
copper. They think it makes, it helps with arthritis, right? So, I in the classic sense of research, controlled or retrospective, I don't know of data that, to Dr. Warren's point, that suggests how copper works. But, from anecdotes, and I say going back to my grandmother, you wear copper and it helps your arthritis. So I'm sure they're seizing on some of that.
Well, I mean, people put onions in their socks and it helped with the cold. So, I mean, there's so many different.
But one of the problems, Patrick, and as you well know, and this is a lot of the biomedical research is supported by pharmaceutical companies,
right?
And they can't make money off of magnets or copper or things like that. They do make money off of naturally occurring things like insulin. But they don't do the research that might support it. But I did want to ask you about pelvic tumors. Have you seen pelvic tumors presenting with venous compression and causing some of the symptoms that Dr. Warren and Dr. Garrison deal with?
Yeah, absolutely. Because for a couple of reasons, besides the mechanical compression of the pelvic veins, and we can talk about the pelvic veins, which I think is the intrapelvic equivalent of varicose vein, is that entity that they call pelvic vein congestion syndrome, right? Where you have these essentially varicose veins in the pelvis that's often treated in a similar manner as how the vein service treats varicose veins in the leg with corrosing and obstructive kind of therapy, where the interventional radiologists use embolization to treat, pelvic vein congestion syndrome. And oftentimes it's a diagnosis of exclusion, right? Once you rule out the GI component, the GU components, and you rule out any other organic components, then, they do this MRI with this post-contrast phase. And oftentimes it shows the venous dilation in the pelvis. And these guys are very slick with their access to the veins through these intravascular catheters. And they embolize these veins. And, I am not going to advertise data that I'm not completely knowledgeable of, but supposedly that's quite helpful. The other way we're seeing, to answer your question directly, is, some of these cancers secrete these thrombotic agents, which causes clotting in themselves, right? And not necessarily because they have caused compression of the veins. They just, for lack of better terms, make the blood very thick. And like you have mentioned before, whenever you have stasis or sluggish blood flow, you do get clots forming. So oftentimes we see patients comes in with new onset clots in the lower extremity and the upper extremity. And when they do the evaluation, whether by MRIs, CAT scans, or ultrasound, we do find tumors. I just operated on a lady this week with a high-grade sarcoma. That's how they diagnosed the high-grade sarcoma. She came in with new onset shortness of breath. She had the pulmonary embolus, and when they scanned her up, she had a big pelvic mass. So to answer your question directly, we do see that quite often.
No, Dr. Anderson, that's really, what's interesting is that sometimes we get the patients that have varicose veins that are going into maybe the vagina or coming out on the pelvis area. And we do make sure that they follow up to have some type of imaging for the abdomen area, pelvic area, because that is also May-Turner's pelvis syndrome are also some of the big ones that cause that.
So, Karma, is that an area that you might get into? I know you didn't want to do hemorrhoids or prostate, But
Yeah.
in females,
No. Yeah, no.
Yeah.
I just say you need to.
Well, I'm gonna take you to the
I
mat
was
on this
just
one,
knowing
Dr.
if you're
Warren,
going to
because
be
here's the
gender
thing.
specific or not.
But here's the thing, the diagnostic components have become so much more sophisticated that, you can move them out of the halls or the walls of big institutions because these devices are not that bulky, right? They can be integrated into smaller devices. So a lot of these evaluations you may be able to do in your office, right? And I think, while we're all excited about the splashdown of the Artemis 2 capsule, this is some of the things that we benefit from by integrating some of this technology into smaller and smaller devices. So, to our advantage, we can move some of these things outside of the halls of the big institution into our smaller offices. So don't give up yet, Dr. Warren. We may be able to come to you for some other things you may not want to advertise, like things like ED and, those kind of things.
Listen, let me do this. Let me do this right now. We have two questions. Let's get to those before the time gets away from us. The first one is, hello, I was in Newark Bethesda Medical Center in 2023 with a blood clot in my left leg and lung. Started on Eliquis in 2000 and then 2025 hospitalized again for blood clots. October 25th in 2025, my cardiologist did a procedure of putting a stent in my vein, he states. Okay, he's putting a stent in my vein. I feel much better, no swelling or pain in my legs. So I'm assuming the cardiologist put a stent in his
Deep,
cardiac.
probably
Yes.
deep.
Yeah. I
probably
don't think the
cardiac.
cardiologist would have put a stent in his lower extremities. And that is tells me that some of the swelling from that he was getting and some of the problems with his lower extremities were probably cardiac insufficiency as opposed to other things that could have arisen.
Well, probably, Dr. Bay, just to add to that, he probably could have had a stent in one of his veins in his legs as well. And then also one of the complications from having large clots in these deeper veins is called post-thrombotic syndrome. And they actually present the same way as your chronic venous insufficiency because they have so much at that time of having that large vein that caused the other veins below it to get larger because they were pushing blood back against this large vein. They end up having the same symptoms of the leg swelling, the discomfort, the heaviness, the tiredness. And we see that as a complication of those big major blood clots that are in the deep system. And they probably they could have had a stent placed in like the femoral vein or something like that.
Okay.
But it's not the area that we work on. Again,
it would be
we
the
do
deep veins.
superficial.
Yeah, because when you have recurrent pulmonary embolus, obviously you start looking at genetics and stuff like that. You start looking at the coagulation system, and especially if you have repeat, and to see if there's some reason is that there are family history and that type of thing for pulmonary embolus.
The real issue is to make sure that this is not something intrinsic in the hematologic side of things in the blood, or make sure there is no chronic structural problem that predisposes to stasis. And when there are structural issues, that's when stents are available, are able to help by keeping the vessel open, or patent, to use those terms. If it's something on the hematologic side, then they have to do what we call a coagulation profile to see what's overexpressed, what's missing, that's making the blood coagulate on its own, right? All these things are benefits that we have intrinsically to help us not to bleed out when we have an injury. But sometimes, the body, overindulges and make a lot of things that has to be utilized in some kind of way, right? And there are entities that makes the blood clot just on its own. So that has to be researched. Usually these things are indication of these things occur earlier in life, not necessarily later in life. Even though later in life you can develop entities that has secondary influence on the blood system, like cancer, that makes the blood clots on its own. And when there are structural issues, that's when stents are helpful.
She answered the question that we were dealing with. It was the deep veins that they put the stent in, she stated. All righty. The next one is in using a leg compression pump. The only way to is using a leg compression pump the only way to reduce swelling in the lower extremities. That was the next question, Dr. Warren. Is using a leg compression pump the only way to reduce swelling in the lower extremities, the lower legs?
Well, no, I mean that's a treatment that we say we kind of accompany along with doing the treatment on the veins on the inside. So those all accompanied with making sure that this isn't having another etiology, whether it's your heart. So there are different reasons why you kind of can make the edema swelling go down. But that is a good way to help. Wearing the compression stocking. And I try to tell people if you could do a minimum of 6 to 8 hours a day, that really does help get some of that back. Dr. Garrison probably wants to add on to that.
Go ahead,
George. Great job. I'm sitting back enjoying you. Excuse me. You know, you got a lot of it, once again, is education not only of the patient, but of the physician, so that there's not a lot of anecdotal medicine being pushed out as opposed to the medicine that is backed up by studies and consensus and things of that nature. And then the second thing is you got to delineate what that swelling is coming from. You know, stockings and compression boots and garments, all that, they're just treating symptoms. But you got to get to the underlying cause of the disease so that you can match the treatment with the disease process. You know, we're talking about superficial veins here. And I just, you brought up something, and I hope to like to direct the conversation to another part of vein disease, is we're talking about DVTs, or deep vein thrombosis, and superficial vein thrombosis. And the treatments for this, because it has been evolving, I remember for superficial venous thrombosis, the treatment was, well, if it was below the knee, just give somebody Advil. Whereas now, if the segment is longer than 3 centimeters, 3 to 5 centimeters, then they need to be treated with DOACs, or these Eliquis and the other medications that we now use that other than heparin and Coumadin. And how long do you treat? And et cetera, et cetera. Now, if it's a deep vein thrombosis, what is the recommendation? What is the algorithm of treatment for that? If it's a recurrent one, what do you do and what do you treat? And these are some of the things that Dr. Warren is faced with in the office, that we get people who are kind of, their treatment plans are all over the place. And what do we do? And so I'd like to, you know, throw that out for discussion. What is a DVT, Dr. Warren, and what's the difference between a DVT and an SVT, and your treatment algorithm for these things? And don't tell me I'm pimping, okay?
Well, I mean, I guess the difference is knowing the DVT meaning DVT, deep vein thrombosis, and that's where, you know, that's where we find the clot in those veins that are in a deeper system. And then you have SVT, which is superficial vein thrombosis, in which those are the veins that we are dealing with when we're treating. And those that are in the DVT, or the deep system, we usually treat those with medications that thin out the blood for at least 3 months. Okay. And then most times you are following up with your PMD. You can also follow up with us, but the key is to making sure that you're on this blood thinner for at least 3 months, right? When the blood clot is in the superficial venous and the superficial system, we are treating that based on the length of that thrombosis, and it's greater than 5 centimeters. And we treat that for 45 days with the same type of medication that will thin your blood. And the thought is that we want to keep that from becoming a DVT, because we're in the superficial system.
Excellent.
Dr. Warren, can you talk a little bit about how pregnancy might influence the development of these varicose veins, the dilation of the superficial?
Yeah, great. Thank you for that. That's also one of the things that I review when the patient, especially my female patients, come in and they talk about when they started to develop these spider veins to visible type of varicose veins to actually having these symptoms. And so during pregnancy, we release hormones. These hormones actually act on these veins that I talk about inside our legs. And guess what? We are carrying another human being, right? We don't get new veins, but we do allow our veins to get large. And that's so they can carry the volume of another human being. So when they do that, the veins become more engorged. We increase the pressure again, and that whole process kind of starts over. And because of the enlargement of the vein, that valve kind of becomes temporarily malfunction during the pregnancy. And so that's where people start to see the veins pop out and they start to have the symptoms. The goal after pregnancy is that our veins will kind of move back to the size that they were before. But guess what we do? We still don't work out as much. We still gain weight. We're still overweight. We still do the things that allow those veins to stay large. So then after pregnancy, they still continue to see a lot of the symptomatology. So when I go over the history, I'm like, so how many times have you been pregnant? So if you've been pregnant more than one time or two times, guess how many times you already influenced those veins to get a little large during pregnancy? And I say, and they're like, oh, I was pregnant a long time ago. I know you were. You were pregnant like 40 years ago, but you still kept doing the other factors that, affected those veins. So yes, pregnancy is very big, and you do see a lot during pregnancy, a lot of the symptoms coming out. But I will say, on the other hand, too, sometimes I see patients that are pregnant and have the varicose veins and some of the edema. And sometimes I say, after pregnancy, see how you're feeling afterwards, because a lot of times the veins will resorb and stop bulging as much, and the symptoms will improve.
Dr. Garrison, your hand's up, and then we're going to take the two questions after you. Go ahead.
Dr. Anderson brought up pelvic disease, pelvic pain, and the treatment of pelvic pain. One of the things that we're doing is to delineate the origin of the pelvic pain. And he said that the interventionalists are thrombosing off pelvic veins. That's kind of not what we do as venous interventionists. Okay, because usually it is caused, the insufficiency or the reflux is caused by an obstruction. There are things like May-Turner syndrome. There are things like Nutcracker syndrome. All of these are usually obstructions of the outflow tract. So instead of thrombosing the vein, which can make the symptoms and the disease worse, what we're doing is stenting these. So we're going away from the thrombotic treatment of these disorders, more towards the increasing of the return, venous return. In addition to that, you were talking about pelvic tumors, and we were talking a little bit. Somebody mentioned ED in men and prostatitis. We are now championing doing venous ablations for those diseases, where we're threading catheters through the superficial femoral arteries into those veins in those areas, into the prostatic veins, into the testicular veins, and into the ovarian veins and things of that nature, in which we can now ablate those veins and therefore decrease the symptomatology of this. So there's a lot going on in interventional venous disease, and although Karma does not want to venture into that, she's like, no, I'll stay right where I'm at. There are some other treatments that are on the forefront that, and again, I believe education of not the patient, but the physicians who are seeing these patients is key. So they get the proper referral to the proper resources so that the diseases that they're exemplifying can be treated adequately, efficiently, and promptly.
All righty.
Yeah, I think though, to when you look at the different modalities that are available and how they're used, it actually relates to the actual physiology of the region, right? So, for example, if you talk about ED, it's more of a pressure volume issue, right? So, if the efferent or if the afferent or the entryway has high pressure, at low pressure, and the outflow is low, the resistance is low, then you get what we call leakage, right? So if to increase the pressure in that region, you obstruct the outflow. So that's where ablative or venous obstruction is helpful, right? So when the blood does come in, the pressure increases, the erection is more turgid. Versus in the pelvis, I think one of the things the interventional guys capitalize on is collateral flow, right? So as you get venous obstruction, it's kind of like having varicosities in patients who have like issues with alcoholism and high pressure in the hepatic system, where you get outflow developing and you get the around like the aorta and the esophagus and the abdominal wall, you get these quote unquote varices, right? Because you have obstruction in another region or another segment of this vascular system. I think that's what the interventional guys rely on, right? Because once they obstruct these dilated veins, then the collateral to the pelvis, which I benefit from by doing resection and anastomosis in the pelvis all the time, the venous system utilizes some of those collaterals to improve the venous flow because those major dilated channels are obstructed.
Excellent, excellent. Let's do this. Quite a few questions. Next question. I have had, let me get this together here, lymphedema over 20 years. My lower legs have been measured up to 26 inches. And then there's another question lower that states, can lymphedema be cured? So two questions. Number one, just someone stating that they have significant lymphedema, but the primary question is, can lymphedema be cured?
No.
Yeah.
So
I mean, I don't know that a cure
A
is
cure,
it
no.
can be managed.
Yes.
I put it that way.
That's what I was going to say.
Yeah, it can be managed through multiple modalities, I guess, of which Dr. Garrison and Dr. Warren have employed some of those. But I also find, and this is kind of like a umbrella therapy, is physical therapy. There are, I see some advertisement for like pelvic floor physical therapy, and one of the advantages, it improves lymphedema. I don't know structurally how implementing pelvic floor physical therapy, how that would help. I guess it's manipulation, massages, and those kind of things that makes it helpful.
Yeah, and to jump on what Dr. Anderson is saying, those kind of things, and there are people like my massage therapist says she went away and took courses and now has become certified in lymphatic drainage procedures with manipulations and things like that. The outcome of those, I don't know, but it definitely would help. And there are surgical practices in New Jersey in which they specialize in lymphatic surgery. Now, what they do are bypasses. They'll do a lymph to vein bypass. Very, very meticulous, very arduous surgery. And the results are they're limited. You might get a 20% reduction in lymphatics, but people with these huge lymphatics, she's talking about a 26 centimeter dilatation. I don't know where that is, if that's at the ankle or at the tibial tuberosity, but there can be some reduction in this lymphatic. And you have to find out what the problem is. Is it a primary lymphatic problem that the lymph is just not working, or is it a secondary problem that Dr. Warren and I can address by addressing the venous disease? So I don't have an absolute answer whether it can be cured. It can be improved. There are things out there that people are doing with this, and I would say a consultation with these lymphatic centers would be in your best advantage.
All right.
Yeah, because there are ways to outline lymphatic channels, right? I mean, Jordan, we used to do this back in the day when we used to bring them down to X-ray, open up the channel above the big toe and inject dye and then trace it going back upwards, right? Now we have ICG and some other sophisticated dyes that we can inject into soft tissue. It gets into the lymphatic channels, and sometimes you can identify them. The thing of it with lymphatic channels, they're very delicate, right? For some people, it's the equivalent of trying to put a suture through a piece of cloth for a vein or an artery versus through a piece of tissue paper for a lymphatic channel, right? And for the guys who do this, the size of the suturing and how they suture And and that's the most things. I think, kudos to them. It's a skill level that take a lot of times to develop and understand.
Yeah.
That's also why, sometimes people get confused about that deep tissue massage and all this to massage to try to help with the lymph system. You don't need that. It's like, so the devices that people use to augment that are so soft that sometimes they don't even think that it's working. But the lymph system is so delicate and so superficial that you don't need that deep to get it up there. You need the soft and the graded pressure of it going up. Yeah, it's a great point.
Let's get another question. Do the compression socks that Dr. Warren recommended have to be medically prescribed, or can they be purchased just through a pharmacy or whatever?
Great question. I think in the back in the day, insurance companies used to pay for compression stockings. I have maybe a couple patients that say their insurance companies will still pay. Yes, they can be prescribed, but you can also purchase them as well. The key is to make sure that you're looking at what the description is with the compression stocking that you're purchasing. It should be medically graded, which means that it is graded as it goes up in pressure up the sock towards the top of the sock. It should be tighter and then looser as it goes up. And that augments as the pressure for the type of natural process for blood going back to the heart. Now, it should be, we typically want you to have, 20 to 30 pounds pressure as it goes up. But some people can't tolerate that, 15 to 20 at the minimum. But I definitely would recommend medically graded so that it has a ramping of the pressure change. And you can get that off Amazon. Sometimes I recommend my patients to get it off Amazon, called True Form. Make sure that you know your dimensions of your thigh, your calf, and your ankle, because you want to make sure that it fits, not just any size compression stocking, but one that matches you and can actually fit correctly, and you can tolerate wearing that. And then also most pharmacies, like CVS, Walgreens, they won't have them. You'll need to go to a medical supply pharmacy. So I failed to mention that. You can get compression stockings at some of these pharmacies. They will not be graded compression stockings. That's the difference.
Yeah, I might ask you, I mean, this is not sexy or anything, but back in the day, Dr. Sprott, you and Garrison used to make us wrap patients' legs after surgery on rounds. Like, did you wrap their legs? That's before we had the sophisticated heparins and Lovenox and things that we use for prophylaxis. Does wrapping the legs with ACE bandages help? And does it require an understanding as to what segment of the leg to wrap tighter than the other?
Well, you got to ask yourself, why are you wrapping the legs? What is the purpose of the wrapping the legs? Purpose is to get venous return, right? And as Dr. Warren has already said, the most efficient way to get venous return is get the patient up and out of the bed and walk. So you get the calf pump. As far as wrapping the legs, if you cannot, you don't have to. What you're talking about is preventing DVT. And the DVT occurs either because of stasis or dilatation or thickened blood. So the patient needs to be hydrated. There's a lot of other things that go into hydrate the patient, get them up and ambulating, and that's the best thing that you can do for them. But interesting enough, there's also you release substances, proteins that your body has natural anticoagulation properties. So you don't have to wrap the legs necessarily to get the effect, the chemical prophylaxis that you're looking for. You could put a compression device on the foot. You could put it around the neck if possible, or you could put it in the arm and still get the same effect of that anticoagulation property. But, excuse me, I'm getting over a cold. Dr. Warren, it's getting ready to be travel season, and people are flying all over the place, and they're in the car for long periods of time. What kind of prophylaxis do you recommend for people who are traveling, whether it be a plane, train, or automobile? What do you think is appropriate? You're muted, Doctor.
I said that earlier, but I again, I tell anybody that's in the car, plane, and you're sitting that requires longer than 2 to 3 hours, to wear the compression stockings.
Mm-hmm. Yeah. Mm-hmm.
Now, if you know some of the other recommendations for somebody who has a history of a DVT or clot, you can do a Lovenox shot before that as well. And that would be like a shot to give for the thinning the blood. But really, the key is get your butt up every, hour or so, walk on the plane, walk up and down, and have that compression stocking on.
Have you ever heard of taking, I know there were some patients state that they take aspirin before.
Aspirin, yeah. I mean, people do take an aspirin. Literature shows the most important thing is movement of that calf muscle. And that calf muscle can be, up and down walking is so important. You just can't sit there.
So get up off the plane and walk to the bathroom a couple of times for long flights, and stop the car and get out and take a break and things of that nature.
I literally said that earlier. It's so important, compression of that calf muscle, which is kind of equivalent to get up and exercise. Every part of our bodies that we are specialists in, whether it's the heart, whether it's the GI tract, digestion, movement is so critical. People just, we become such a sedentary society, and we are causing so many health problems just because of it. And it really is important that we are more active as a people, and exercise is important.
Right.
Dr. Luca, I have a question for you. You've been sitting there very quietly and patiently. I have a question. What are the advantages of using a DOAC as opposed to heparin or Coumadin, and what is your practice algorithm in using these medications?
Yes, so good afternoon, everybody. I've just been listening. Sorry I came in late. I had to finish up with clinic. So, well, the first things that we have always had, I mean, I think Dr. Anderson was saying something about wrapping the leg back in the days before all of these fancy things came up. Getting patients out of bed is very important, no doubt. But then we had Coumadin, right? Coumadin has anti-coagulative effects, begins with, 7, 5, 9, and 10. And within, a day, 2 days, and now it breaks down. But then the problem with Coumadin is that, one, you have to measure it. And you have to, in measuring it, you have to draw blood, run it, and have to follow, and then adjust the meds accordingly. But more importantly, the drawback of that is it's seriously really affected by the food you eat, meaning green vegetables and all the other stuff. So you have to constantly adjust that. And it's hard for people to all of a sudden who had a blood clot to now, adjust or resume a new kind of diet. So that's where the big issues have always been. So, but a little bit of a historic perspective was that if you in the US compared to those in China or in Europe, they have different PTT, level and INR there. And that's why they came up with the INR, International Normalization Ratio, so that globally everybody have one number, so that whether you travel from one place is the same. So we have that. But then we still have the drawbacks. It has to be maintained for those with valvular heart, non-valvular heart disease, 2.5 to 3. And if you have valvular disease with a prosthesis, 3 to 5. Those are narrow levels. So people went up and said, and because there was issues about bleeding in the brain, the risk of bleeding in the brain when you have an INR greater than 10. Now, 5 to 7, you can bleed GI or otherwise. So, but those are big issues. And we had people who died from it. So people did some research. And of course, heparin is there. Now, heparin, you have the big regular heparin and you have the low molecular weight heparin. Now, the heparin issue, as you know from history, came from, the guts of cows and stuff. But they were high molecular, materials. So you inject it, it's fine, but you have to inject it multiple times. Now we do it 3 times a day. Now, with the high molecular heparin that you use, the big problem with that is they are big molecules, And when you inject into the system, it goes into the system and it can bind to platelets. So that's why you have the heat, you know, one and two. So and then you produce the what you call that what's it the enzyme that you produce? I've forgotten now, but I'll tell you what I remember. So it becomes a problem that for those who have that heat one or heat two, meaning heparin-induced thrombocytopenia because it eats up the platelets. Thrombocytopenia has, low platelets. So if it happens, then you cannot use heparin anymore, and you can't use heparin for life, basically. So of course, other people went on to do more research, and then you have the DOACs. So the DOACs, so the process is, like I said, the clotting system, you have 7, 5, 9, 2, and 10, and then 13 as a component. I don't want to go into details, but some people were so smart enough, looked at the area and say, you know what, if we block it at the 10 level or block it at the 13 level, it's a lot more effective. And you can do it in such a way that you rather than injections, you now have the tablets. And you don't have to monitor the tablet levels. And that's why we have, the Xarelto and the Eliquis and all that we have now. Thank God you don't have to monitor them and you don't have to do anything else with them. But they have their drawbacks as well. They're pretty new in the in medicine, not maybe about 10 years or more or a little less. So now we have all these ranges, right? So what are you going to use at any point in time? If you're in the hospital, and then you have the cost as well, because the DOACs are a whole lot more expensive. Insurance company may not want to pay for it, especially when you leave the hospital. And then if you leave the hospital, they don't want to pay for it. And if you leave, sometimes they don't want to pay for the heparin as well. But then you have to use the heparin multiple times. So it's a big problem. So in the hospitals now, we choose either heparin, which most insurance will pay for. But for those with, bad insurance and, tolerance, or if you refuse to take the heparin because it's 3 times, now you do the, what do you call it? The low molecular weight, Lovenox, right? So you take the Lovenox, and those ones you can do, once or twice, depending on the dose. You could do 1 per kilo twice daily or 1.6 per kilo once a day. And that's the way they do it. So, but the DOACs, the problem now is choosing which one is which. Now, Xarelto one time became such a big deal. Eliquis was a big deal. The other ones, depend on what individual. Now, if you notice, the gentleman who said earlier on was that he was on Eliquis and then had a blood clot. In my experience, I've seen a lot of people on Eliquis, then they now get a blood clot on top of it. The question is this, and then this is where I bring it down to who are we? You understand? A lot of this research that we're done on all of these meds, how many of our people were in those research? 5, 2%. So what all of these things really done for us and well for us that really protect us, we don't know that yet. The jury's still out there. However, I would always say choose the best DOACs or anticoagulation that is safe, that's tolerable, and that you have the best experience with. For me, it's with Xarelto. And that's what I stick on. And I've had good report with that, and I continue to do with that.
Yeah, I think that a basic anticoagulant, and you went very good. You went through the history of anticoagulation there, actually. I think that usually either if it's a DVT or a pulmonary embolus, and it's either a pulmonologist or either your primary care doc. I'm a big um, I'm big on having a hematology consult. And reason being is that, sometimes you don't know, especially if someone comes in with an extremely large clot. But, like if we in pulmonary call it a saddle embolus. This clot is significant, it's large, it's in several arteries in the pulmonary arteries, the lung arteries, and the patient is quite sick, It can be life-threatening. I'm a big person that usually I like my patients to at least get that hematology consult to be followed up by the hematologist
In
to
the
make sure
hospital,
that
right?
But
appropriate.
that makes total sense because all the things that Dr. Garrison, Sprott, and Warren has said that we can do to help, decrease the risk of getting these varicose veins and developing
Right.
these clots is exercise, movement. You have athletes who develop these things spontaneously, right? And they're the ones doing all the things that are recommended. So in that scenario, for sure, you need to make sure that there's nothing intrinsic on the hematologic side that puts them at risk for
Right.
some of these spots.
So that's that. You see, I'll tell you this. Over the last maybe 5, 10 years, I've seen people come up with DVTs more frequent than it used to be. And these are younger people who are truly, like you said, athletes are very active. Now, the big issue is this. When they come up with having, a DVT, especially the younger person and someone who's very active, they usually 90 to 98% chance there's an intrinsic or underlying coagulation defect. And we have a whole series of them. And once you have a DVT, the first thing they do, they put you on those meds. That is not the time to screen that individual for those defects, because then the whole coagulation system is in disarray anyways. So you have to be on them, 3 months and after that, when they come off, then you can now screen them. And a lot of the time they have the protein C, protein S deficiency or the antitrophin 3 defect that they tend to have. So you have to wait for when that is done. I've seen a young guy who was 23, got up, an accountant got up, hit his leg against the chair, and boom, DVT. I had a guy who was playing soccer, went up to, kick the ball, he kicked another person else, DVT, and he actually had a P on top of it. So we've seen a lot of all these things. So the question is, why? Why is one? Is it the food that we eat? Is it our diet now that's increasing our procoagulable states to the point where we begin to see some of this? I guess we'll still work hard more and see what's going on.
Right. Oh yeah, Dr. Jordan Garrison. I know that you're talking, but you're on mute. And
I'd like to weigh in on that, and then I have one question. I'd like to weigh in that, a lot of this, when we talk about the triad of why you get a DVT, you've got people that are exercising more, and our training methods have exceeded what our physiology is. Our physiology hasn't caught up yet. So we're training harder. We're getting people with effort-induced thrombosis. We're getting people with DVTs. And I think it's training and lack of hydration in conjunction with that training. But I have one question. And Dr. Rosemond, don't think you're going to get by just listening today. I got a question for you. Okay. How do you treat somebody with bleeding gums and they may be on an anticoagulant? Like we're talking about these DOACs. We're talking about, Eliquis and Xarelto, or even Coumadin. How do you approach this with somebody comes in with bleeding gums? And by the way, could you give me your phone number as well? I need a dentist. Okay.
I'll send you offline my number. That is a significant concern that we experience. So the primary inflammatory response due to poor oral hygiene is bleeding gums. We also have the problem with a lot of patients being on various meds that are necessary, such as with our cardiovascular partners as well. So for us, it's very critical that the patient go in a strict hygiene regimen, because we don't want to start out by changing their medications, but sometimes we have to get to that point if we can't get it under control. But it is a significant risk factor, and we even encourage some of the physicians when they're putting patients on certain medications, particularly right now, a big medication is oral bisphosphonates, that to have them get a dental clearance, because it does create some long-term issues for the patients. But overall, right now, we just try to clean up their hygiene situation, reduce that inflammation, but also communicate with the clinician that prescribed those meds to see if we can get it under control, because it can
Could
be
you
a
tell me
long-term issue.
what is oral bisphosphonate? What is that?
Oral bisphosphonates,
Those are medications that we use for like osteoporosis, those kind of things.
Correct.
You know,
Okay.
Evangelinate, you know, those kind of medications.
Like
It-
Fosamax, stuff like that.
Yes,
yes,
Fosamax, those
yes,
kind of things.
exactly,
Mhm.
exactly.
Yeah.
That's a big challenge. It's been given a lot lately in the medical community, but it's critical that those patients should get a dental screening before you put them on those meds for a long-term period of time.
Hmm.
You know, and I'm coming back at Dr. Warren. It's interesting how all the systems, you know, are integrated, right? I often say when you turn the key in your car and that check engine light comes on and then goes off, you know, it's the ignition, the fuel, the brake system, all saying to themselves, yeah, guys, we're ready to go, right? And, you know, patients who are postmenopausal, we talk a little bit about pregnancy. How do you see hormone replacement therapy influencing some of the varicose veins that you see the incidence of and the response to treatment? Because now, you know, in the recent past, folks are are usually skeptical about hormone replacement therapy. Fast forward to now, and they're looking at some of the older studies, like the nurse initiative study, and saying there were some of these studies were flawed. They could have been statistically, they could have been evaluated a little bit better. So there's more benefit to HRT, hormone replacement therapy, than not. Do you get involved with counseling some of your female patients regarding HRT and how to manage your varicose veins?
I don't. Um, I, I guess in the sense of telling them no or yes, but there is obviously the increased risk factor for having CVI with hormones, estrogen and progesterone in the body. The same thing as when they're pregnant, it does the same type of influence on the veins having the hormones in there. But as a female physician who has gone through menopause and is on HRT, I do if patients have asked me, I'm like, hey, you need to talk to your gynecologist. It's not what you thought for these many years that I'm going to get cancer by getting on the HRT. So that part I do. But as far as just having extra hormones in your body, we were zero and we just added the hormones that were replaced. So yeah.
I have one question, and this is going to be the last question. And I promised Dr. Ali that we were going to we were going to pull hemorrhoids into this conversation. And so the last question is going to be hemorrhoids as far as veins being dilated and the bleeding and how does it is it associated with other veins, you know, like the lower extremity veins or the pelvic veins or the, you know, that type of thing, or is it its special entity?
I think it could be a combination of both. You know, hemorrhoids, what those are, just engorged hemorrhoidal veins, right? They're draining the anal rectal area, and you've got kind of an inferior and a superior supply that then will go back into the venous system and goes back into the heart. But what happens is we all have hemorrhoids. We have what we call hemorrhoidal columns. We're born with them, right? And these vessels over time, they just kind of live down below, but as they engorge, like everything else we've discussed today, they engorge, and when they engorge, they push up against the bottom part of the rectum or the wall of the colon, and they then can become bigger over time. And there's two kinds of hemorrhoids. They're what we call internal hemorrhoids, and those are the ones inside. You don't feel them, you don't see them. And these ones can cause what we call painless, no pain, bleeding. You go to the bathroom, you see blood coating the stool, you can see blood in the toilet paper. Sometimes it could drip a little bit, and it could be quite startling. The other kind of hemorrhoids is what we call external hemorrhoids. And those are the ones where the blood vessels are on the outside. These are that part of the where the anatomy is, there's a lot of nerves down there, so you could feel those, and they can hurt, they can come out, they could look very uncomfortable, and that's something that can evolve, and over time they grow. Why do people get them? It could be from increased pressure, straining, constipation, diarrhea, for sitting for prolonged periods of time. Weightlifters, sometimes if they're increasing that abdominal pressure. Pregnancy could also lead to this because of the pressure down below, right, with the uterus. So there are a variety of reasons why people can get them, and so it's all related.
Mm-hmm. All related. All right. Yeah, that just sums it up. And I think what it's doing is just pulling it all together, letting us know that the body works as a unit. And you'd be so surprised how, your little toe is hurting, and it has something to do with your ear. You know what I mean? That's how intertwined things are as far as the body is concerned. Dr. Luya, I see you have your hand up. I want to give you a tenth of a second to sum up because we're way
Right.
over time.
All right. So thank you very much. This question is for Dr. Warren, and thank you for coming, actually. Good to see you again. Now, understanding that lymphedema cannot be cured, what are the possible long-term complications of lymphedema if cannot be cured or not properly treated?
I mean, not cured. I think we all kind of said earlier. I mean, the key is just multifactorial approaches to making it livable, right? And having relief for the patient so that they can continue to move on. But no curing, no, but definitely helpful approaches for allowing the patient to feel better.
Mm-hmm.
Yeah, I think
Any
if we can
long-term
avoid
complications?
ulceration, if we can avoid ulceration, increase mobility, that becomes part of the management. Because I think once you get ulceration, skin breakdown, then infection creeps in, and then it becomes problematic.
Yeah, I guess it also depends on what stage of the lymphedema they're in that allows that approach for it. When they start getting the ulcerations and so forth, then your main focus is trying to get some of that ulceration curing and wellness with that versus just the overall treatment for the lymphedema.
Any risk of cancer
from the lymphedema? Not that I know of.
But if you talk about the ulcerative process, anytime you have continued trauma to an area, there is a risk of DNA alteration and cancers. And we do see some venous cancers if left untreated for an extensive period of time.
Mm-hmm. All right. Excellent. I think this was such a needed discussion. Excellent. And Dr. Warren, thank you very much, so much for coming and tolerating all these brothers.
Dr. Warren, you should remind them that soon Summer will be here and we'll be looking at the breast cancer event that you guys hosted in Orange Park in collaboration with East Orange last year. I thought that was fantastic. And I hope you guys are looking to do it again this year.
Yes, we are. Thank you so much.
Yeah. Mm-hmm. Yeah. And to end up, I just want to talk about a New Jersey Medical Association. It's having his scholarship gala for all the physicians here that may want to attend. What we do from New Jersey Medical Association is the New Jersey chapter of NMA, which is the National Medical Association for Black Physicians. Basically on April 22nd. We're having a scholarship gala, and this is to promote medicine on the high school level, in the college level. These young people, they write paragraphs and essays, and we read those essays and decide and give out scholarships through that. And Dr. Warren and Dr. Duncan, you're very much a part of this, and we're so appreciative of it. It's April 22nd. Also, what we do is Black and Latino residents or fellows, we recognize them at the gala as well. So throughout New Jersey, we let the programs know that we are going to recognize any Black student of as far as medical school, as far as residency concerned, and as far as the fellowships are concerned, to come to the gala, and we recognize them and just love on them and just let them know how much we appreciate them and so excited that they decided to come into medicine.
Hey, Omar, I want to buy a ticket. Where can I get one from?
I'm going to give you this. Yeah, just take a pencil, get a pencil, and
Got it.
I'll read this email out to you. It says, for more information, it's NJMA. That's for New Jersey Medical Association. MJMA President, and you President, President at gmail.com.
Dr. Beck, can you put like maybe the QR code on your website? So
Uh,
that,
I probably
or
can
send it out to
also.
your partners, to the
Oh, yeah,
brothers.
yeah. What I can do is what I'll do is I'll just send out this email to everybody. How about
Yeah.
if I do that?
We're
And
always looking for sponsors.
yeah, oh yes, please. We're looking for sponsors. We're looking for people just to come and sit in the audience even because it's such a great event. I mean the kids are just so wonderful. The essays
Yeah.
are excellent. The parents come and they're so excited about this. It's such a wonderful event, I must admit. So yeah,
That's
we
all the Rowan, New Jersey Med School, Robert Wood programs everywhere. So we try to
right,
get all
Beth
the students
Israel,
from
their
everywhere.
residents, all that. Let me give that for those who are listening. Let me give that email, or just in case you want to let someone know, or if you want to come. That's NJMA. All right, get a pencil. Excuse me, MJMA President, President at gmail.com, and it's on April 22nd. It's going to be at the Montclair Art Museum, and that's a wonderful site too to come and visit. And that's on 3 South Mountain Avenue in Montclair, New Jersey. And yeah, definitely. If you have a question, you can email me at OBHealthy. Just go on the website, send me an email. Um, and I'll try to answer any information as far as I can send you any information as far as the scholarship gala is concerned. We'd love to have each and every one of you who are out there listening, as well as the physicians. And yeah, it's just an exciting time that we have there. All righty. Anything else that I missed, guys? Because we're going to end this out. And if we have
I
exhausted
just want to
ourselves,
say,
go
Dr.
ahead.
Bay, I just want to say thank you to all of my mentors and all of you who have been so influential in my medical journey career. And thank you for just being the epitome of what we need to be for our younger generations and for setting the pace for me and knowing what I need to do because of you. So thank you so much for giving me this opportunity to be here today and for giving some education to our community, because that's what it's about and that's what we should be doing. Thank you so much.
Oh, listen, we appreciate you enormously. It's just we hear all the time. Well, I hear all the time how great you're doing out there and all the things that you're doing, and I'm like, yeah. So keep on doing it. Just keep on doing it. I love it. I love it. All righty. So in closing, thank you to OB Healthy for letting us use their platform so we can bring this webinar to you. Understand, please tell everybody it's every second Saturday at 1 o'clock. But understand that months coming, we're going to be taking some months off because of vacation time and things like that. So just let you know, the docs need a break. So we are going to have some breaks in there. It's all about caring and sharing. So let your church members know, let your fraternity members, all people that you think that could use what we do here and ask their medical questions so we can answer them, just let them know about it. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor can best take care of you from a medical standpoint. Alrighty. You can see all of our past webinars, and believe me, we have a ton of them. I think we have about 75 or 80 out there now, and they're all different topics. Just go to OBHealthy, just click the YouTube tab and look at the titles. If there's a title that interests you or you want to know about, or you're having a medical problem, just listen to the tape. It's all there. Please. All right. I look forward to seeing all of the docs and hearing from all of the people out in the audience next time we have the webinar. All I can say is just spread the word. Okay, guys? And we will see you not next month because I won't be around, but the month after that, we're going to have it. All righty. So we're going to give a month off there. And then the month after that, we will be back and we'll move forward with this. All right. Until next time, I'm going to say peace. Peace to everybody.
Peace and love, right?
All right. Peace and love.
Bye-bye.
Yes, definitely.
See you
All right.
all.
Take
right.
care, everyone.
Take care.
Take care.
All right.
Bye-bye.
Take care.
All right.
Bye-bye.
Bye-bye.
Hey, everybody have a good day.
All right.